Respected dignitaries on the dais, my dear friends, this is Aishwarya and Jessica Jacob, the way present case. Mr. Y, a 68-year-old driver from Nagarkoil, came to the OPD with chief complaints of upper abdominal pain for the past 2 months and vomiting for the past 2 months. History of present illness: the patient was apparently normal 2 months back when he developed upper abdominal pain, which is gradual onset, intermittent, non-radiating, dull type of pain, aggravated on protege. No treatment was taken the same. Patient also complains of vomiting for the last 2 months, occurring almost every day in the last 1 week, which is 4 to 5 episodes per day, spontaneous, copious in amount, non-venous, non-rustling. It occurs 2 hours after the intake of food and contain partially digested food. There is history of loss of appetite, loss of weight, and history of generalized weakness and fatigability. History of all-rolling bones are present. No history of passing black garden stools. No history of hepatitis, no history of yellow discoloration of urine, eyes, skin, no history of breathlessness, hemoptysis, or body pain. Past history: no history of similar complaints in the past, no history of diabetes, hypertension, tuberculosis, epilepsy, asthma, no history of any previous surgery. Drug history: there is no any drug history and no history of any allergy. Personal history: the patient continues to mix the diet. The sleep is disturbed due to the abdominal pain and bowel habits reduced frequency as once in 3 days. Bladder is normal and the patient consumes alcohol for the past 30 years and also smoked for the past 30 years. Family history: no history of any malignancy in the family. Summary: 68-year-old gentleman who has history of smoking and alcohol consumption for the last 30 years, present with chief complaints of upper abdominal pain for the past 2 months and vomiting after 2 hours of consumption of food for the past 2 months, associated with loss of appetite and loss of weight, and history of bowel is present. Probably a case of gastric obstruction.
You believe that gastric obstruction can come in 2 months?
Sir, if the obstruction is malignant in nature, it can aggravate in a short amount of time, short time.
Intense only, no? Once intense is
the patient was asymptomatic. Yes, sir.
Is he asymptomatic or you are not asked?
The patient had now complained of vomiting or abdominal pain before.
You are not asked. If you spend time with the patient and ask her what is the complaint and how long he is having this problem. So these are the gastric obstruction, not a one-day disease, or it is not a one-month disease. It is a one-month. So, and loss of that periodicity, asking for the periodicity of the pain, all that is very important for
dyspepsia previously.
No,
And the 2 months, anything like that.
no, sir. No.
I would also request you to change this word, apparently normal. Patient is not abnormal now, he's a patient, no? So some people can take it to heart that why are you calling them abnormal? So patient was apparently well 2 months ago, and when he started noticing these symptoms, maybe a better way to write it. And is 2 months onset a gradual onset?
2 months, the pain was initially
one fine morning when he is getting up on that rainy Sunday, he developed that. Is life like that?
No, sir.
Okay, it must be there for the continuation here. And now you come to the conclusion that you are vomiting for every day 4 to 5 times?
For the last 1 week, he has been vomiting for every day 4 to 5 times.
Okay, he is dehydrated now.
Yes, sir.
Okay. So why there is vomiting after 2 hours? That also we are very specifically saying.
Because of obstruction probably in the distal part of the stomach, sir.
No, why vomiting after 2 hours? Why not immediately? What you had in the morning today? Breakfast, what you had?
Pongal.
Where is it now?
Probably the intestine.
Gone to the intestine. Large intestine has gone. How much time it takes to pass over the stomach to the
1 and 2 hours. 4 hours.
Okay. No, why we are asking this question a little sarcastically, but when you are asking the history, you should little more spend time. When he says 2 hours, then you must ask how it is possible, why it is there, and then you will answer this. Don't just take it as
So we are not able to understand the type of pain also. You're calling it intermittent non-radiating and then dull aching. Now, I mean, what we want to know is it a dull aching kind of a visceral pain that the patient is having due to distension of stomach, or is it that this patient already has dull aching pain which is superimposed by severe attacks of colicky pain? What is happening? Are we dealing with mechanical obstruction, do you think? Are we dealing with some kind of functional obstruction?
It's probably mechanical obstruction because of any tumor.
So in mechanical obstruction, pain should be severe. Why should pain be dull aching in mechanical obstruction? So you need to again take this history more carefully, because I'm sure patient must be having dull aching pain continuously with intermittent attacks of severe pain in the abdomen. So cramp-like pain the patient will get in the abdomen.
What do you mean by not radiating? Where do you look for the radiation?
Towards the back of the
What does it indicate?
pancreatic.
No, you are dealing with the stomach.
Any tumor infiltration.
In the anterobral wall. Is it in the anterobral wall you are meaning?
So please phrase your answers correctly. You've been asked a very genuine question. You've only talked about radiation of pain, no? Yeah, so what you need to, you're trying to say is that you want to trace the cause of what you are suspecting is gastric outlet obstruction. You're taking history with respect to that. Now it could be like we talked about intramural, or it could be extramural also. So for stomach, you're talking about pain in the back can happen. Pain can also happen elsewhere, where? In stomach pathologies. So then you start ruling out, no, patient may get jaundice due to obstruction of biliary channels. There can be continuous dull aching pain in such patients even otherwise. And pancreatic pathologies, you rightly said.
So what do you mean by radiation? That's all. What do you mean by that radiation? What is the mechanism of radiation?
Referred pain is when the action pathology is in some other visceral organ and the pain is perceived in another part where both of which share the same ground floor.
So referred pain or visceral pain?
The pathology.
Is it a visceral pain?
No. The referred pain is.
What is it then if it is not visceral?
What is visceral pain or what is clinical pain?
Visceral pain is in the visceral organ.
Which nervous system is involved? No, referred pain, what is referred pain?
Referred pain is the pain which is perceived in another part which shares the same dermatome as the organ where the.
What do you mean? What is dermatome? Unfortunately, that word is now frequently everywhere. What do you mean by the dermatome?
Nerve supply, the region which is supplied by the same nerve.
They develop from the same somatic.
So you must read the mechanism for radiation in continuity. When it's a disease progress, you are going to get it. Referred pain, the afferent and efferent nerves are going to be different. The afferent nerve is, but all have the same root value. They are processed in that particular area, but the efferent impulse is coming through another nerve, not through. Usually it comes the same. You talk about gallbladder disease or diaphragm. The afferent is going to the phrenic nerve, efferent is going to the supraclavicular nerve. So you are going to get a pain in the shoulder. So it is entirely different mechanism. It's not purely talking about a dermatome or the one particular area where that area is applied. It is processed in the brain, but the signal is sending from a protective reflex. Pain is always a protective reflex. So it goes through the different. So do you get an preferred pain in the stomach? Where? This naturally, any visceral pain, there is no localization. Always visceral pain, the foregut pain will be in the epigastrium, midgut pain will be in the umbilicus, hindgut pain will be there. Skeletal pain will always have a localization. Where you touch, you have a pain. But here it is a diffused pain that you get. Okay, go ahead.
So was the vomiting projectile? Was it non-projectile?
Non-projectile.
Non-projectile means?
It is
Induced.
no, sir. Spontaneous vomiting.
Spontaneous may be projectile also? Head injury, you get spontaneous vomiting, which is projectile.
This is my nausea.
What is the content of the vomit is content?
And it's partially digested.
Partially digested. And you said no blood stain. Non-bilious. Why non-bilious?
Because there is no obstruction of the lower
Obstruction is probably at the gastric. It is not reached the intestines.
How do you know it is non-bilious? How do you ask the question? No, how did you ask the question to the patient? Saying it is non-bilious.
color, sir. We asked for the color of the vomit test.
So if I take coffee, it will be brown color. So if I take a manchal, it will be yellow in color. That is what you take, the partial food. It has all the contents coming out.
No, the ileus vomiting will have a very bitter taste.
Okay. He says satiety.
No, sir.
No satiety. What do you mean by satiety? What is mean appetite?
Appetite is what we feel before having food. The urge to have food. Early satiety is when after.
Why there is less appetite for this patient?
Because loss of appetite is because the patient has been vomiting frequently after taking food, so he's probably.
Your principle you should have increased it because his urge to take food will be
Vomiting, you will feel hungry more.
will be hypoglycemia.
Early satiety and appetite. What is the difference? And what is the significance of early satiety?
Early satiety is because of any.
Loss of appetite because there could be malignancy.
That's correct. Where is it? What is the reason?
So it's a very interesting.
Early satiety used to be fullness happening in small amount of body. Obstruction due
Because any other mass is occupying space.
So you are right to say any other mass. Can it be from the stomach itself?
they
How much biryani you can take? You take one biryani, full biryani. Your stomach can accommodate. So what will happen? The early satiety. Your stomach is not accommodating.
Because of muscular image contract. Distance.
You, you have written pain is aggravated on food intake. Are there some pathologies in upper GI tract where pain may get relieved on food intake?
Duodenal ulcer. Duodenal ulcer, pain will be from food intake, so the patient tends to take more food.
You are contradicting your own food. The pain is as soon as taking food. But vomiting comes after 2 hours.
did the patient have melena? There's no mention of melena in your present, is it? Have you mentioned? Did I miss it? What is melena?
Fasting lactase stools.
Give us complete definition of melena.
Melena is actually black star stools which sticks to the pantry. It's because of the conversion of
What do you mean the tar is to?
tannin. It's black and sticky.
Sticky, black, and another one more correct.
Large volumes of foul-smelling black tarry stools that stick to the pan.
Due to what?
Upper J.
What is upper J?
So the DJ rodent is the pressure.
Up to what?
So it is not duodenal jejunum.
How will you identify it? Okay. Can you, postgraduates are here? Can you get melena in the lower bowl? Lower G, what will you D2? Oh. So upper GA you have oxidative meaning, acid metabolism. Here because the transit time is more, bacteria time is oxidative reduction. You can get this. But undergraduate you can still see the upper GA alone because.
So what are these ball rolling movements that we are talking about?
Football, cricket ball, volleyball. Which ball is it? How did you explain? What is the explanation patient has given?
Patient actually complains of movements in the, he feels perceives movement inside the epigastric region.
After taking food or normally we are without taking food?
After taking food.
That is for everyone. You take full biryani and walk, you will feel some discomfort.
Because of fluid collection, retention in the stomach.
Okay, that is significantly patient is complaining.
But the generalized weakness of the fatigue, why do you ask that?
Because the patient can be
The patient has been vomiting the last 2 months, also has lost the appetite and lost the weight is there. So,
What happens?
can fix.
Fatigability. Particularly I asked why it is a fatigability and why it is a weakness.
because the patient is dehydrated
And then also
and there's also anemia, chances of
dehydration along with loss of some
loss of
electrolytes.
electrolytes.
Again the question for PGs. If there is no anemia, means no blood loss, melena, can he get anemia? How? There is no metamesis, there is no melena. The internal bleeding will manifest with melena. Very good.
Aciduria, acid from the body. Paradoxical aciduria will cause
That is a different mechanism.
That is so different. We say there is an ulcer, this is a malignancy we done. Okay, what happens in malignancy? What happens to the acid level in malignancy?
it decreases in the body.
So a chlorate, conversion of the acid is for the absorption. You may get an anemia.
Intrinsic factor will reduce, so stomach produces intrinsic factor of acid, which is reduced. So absorption of vitamin B12 reduced.
Again, PGs, when there is anemia, one disease normally will not come, one infectious disease. Malaria will come. Malaria will come. The ferritin level plays a major role as a protective factor in the liver. One abscess. Amoebic liver abscess.
You mentioned that patient is a smoker and consumes alcohol.
Yes.
How can you correlate it with gastric outlet obstruction?
Smoking is a risk factor for gastric cancer. Smoking is
These are risk factors. One is that you think in terms of stomach malignancy. Why I brought this up was that you should have specifically added that patient did not have any acute attack, because history is that of 2 months only, no? What if I say patient had an acute attack of pancreatitis some time back and is now developing a pseudocyst which is obstructing? So you keep your mind open when you are taking history. Don't assume that you are moving in one direction only.
Because we are short duration, 2 months, then all other options we have to keep. Okay. Examination. You are too early. Hungry.
general examination. Consent was taken. Patient was examined in a well-lit room with adequate privacy in the presence of another. Patient in supine position, exposed from the level of nipple to midline, must stand on the right side. Patient was conscious, collective, oriented to time, place and person, moderately built and polynourished, signs of dehydration present, no pallor, interest, cyanosis, clubbing, lymphadenopathy or edema. Vitals, temperature line.
Previous vitals we have missed. We have put a BMI, some kilometers. What is that? Kg per meter square. What do you mean by that? What is that kilogram per meter square? Is it the unit or is the formula which we are used to find out the BMI?
It is both the unit and the formula.
Unit also.
Kilogram per meter square.
It's not a unit, so we are not supposed to put the unit there. It is a formula which we are using to find out. It is a number. 6. Why do we use this meter square? Have you read any dose of the chemotherapeutic drugs? What is the dose of common drug, cyclophosphamide? There we always say per meter square. What is the normal meter square of you? You know your weight. What is your surface area?
What is the range? 1? You are right, say.
1.73. That surface area. That is why we are going to, when we are giving chemotherapeutic drugs, that we are going to put that. And here, always better to put that. I know that some of the books also mention like this, but it is better. This is only a formula which we are using, so let us not put that formula. We don't put that formula for any other day. And signs of dehydration present. What are the signs?
So screen color is lost, conjunctiva is dry and then dry down. Urine output is reduced.
How long is the hospital?
For
1 week you are keeping the patient tongue dry and skin turned. That tells bad about the house surgeons. Okay, go ahead.
vitals, temperature 98 Fahrenheit equivalent, pulse rate 78 beats per minute, blood pressure 180 millimeters of mercury, respiratory rate 18 beats per minute. Abdominal examination, inspection, fullness seen over the gastric, umbilicus, normal position and inverted, no scar, sinus, dilated veins over the abdomen, all quadrants move equally with respiration, visible gastric peristalsis seen, single wave from left to right.
What did you examine? Visible gastric peristalsis.
So we have to stand at foot end of the patient to tangentially for
What is tangential?
15 feet on
Bend slightly.
Surgeon should never bend.
What means tangentially just
At the level. You can put a stool, sit and listen. Never in the life or in the surgery or examination you should bend. It's always upright, surgeons. Okay? And Madam has shown a beautiful picture. So what is that gastric peristalsis? It goes from left to,
right.
then what happens?
Then it slowly fades and then slowly diffuses in another. Next phase starts.
No, this wave is disappearing. Is it one way direction or it will turn back or?
Just put it inside. See where what happens.
Go back and
Yes, the stomach will be dilated, it will be slowly increased, that which you can't see. Then again the second wave, the wave starts from where? What is the pacemaker of the stomach?
he says it says some part.
Okay.
Hernia verifies free, clamps free, cells are normal, no nodes seen. Palpation, no local rising temperature. Mass in the epigastric region, upper extent 2 cm from cervicsternum, lower extent 3 cm from umbilicus, left border at midline, right border at midclavicular line, measuring 5 or 6 cm, irregular surface, well-defined margins, hard in consistency, non-tender, moves with respiration. Fingers can be inserted between the mass and cervicsternum, no other mass palpable. Liver is spleen, not palpable. Hernia verifies free, external cells are normal, no nodes palpable. Percussion, impact distance over the mass, no evidence of free fluid. Liver span 12 cm, upper border liver levels only from 2 cm intercostal space, 6 cm right costal margin. Auscultation, normal water sounds heard, succussion slash positive. Auscultative percussion, brain culture lying about the umbilicus. Distal rectal examination to be done.
What is succession flash? You said the stomach is distant, no? No, no, greater curvature lying above the umbilicus space.
That's not correct. It depends on the shape of stomach and you've not drawn a diagram.
You must have a diagram of the auscultative. How will you do suction flash? How will you do auscultative?
So for succussion slash, we have to keep the set in the.
After doing ET.
No, sir. Succussion slash has to be a minimum consumption of any food or because any food. We have to keep the
What is the saline loading test, madam, sir?
saline loading tests are aspiration of first aspirate contents in the stomach, then we have to infuse saline, 750 ml of non-saline, and make it hammer it, and then we wait for 30 minutes, regularly aspirate the saline. And if more than 400 ml comes, that means there is any obstruction.
There will be some fluid will be left over. Why you are doing the suction? So you put a stethoscope where?
Yes.
So suction slash we place the stethoscope in the gastric, fix it with the 2 fingers and steadily.
You have only 2 hands.
2 fingers.
So that is 2 fingers. Not shake.
Or like the thing should be posted.
Fix with the hand and shake.
Shake the patient, and if there is any splashes present, then suction slash is posted.
You should ensure that there is no nasogastric tube in place, and there should be no nasogastric tube in place when you do succussion splash, because you may have already aspirated everything.
Hospital location, we have to use the bed of the stomach and place it in the epigastrium, and then we start scraping from radially from left to right, start scraping, and then there is a change in the mode. We mark the points, connect it, and that gives us the conversion.
So according to you, it was above the umbilicus. So there was no much dilatation.
Not much time.
You've mentioned about lymph nodes were not palpable. Which lymph nodes did you examine?
Supraclavicular lymph node,
Make a special mention of that. And in abdomen also you have written no lymph nodes were palpable. So
left supraclavicular lymph node.
that is fine. Go to examination of abdomen, the previous slide. You've written no nodes palpable. How do you say that the mass which is palpable is a mass of lymph nodes, or is it something else?
No, you said irregular, nodular surface. No, why not it is a node?
What test you did to say it's
Do you know it is just a mass that is palpable from the stomach, and it's not a mass of lymph nodes with the mass in stomach, or
You have said you have done a test. What was the percussion?
Percussion impact resistance over the mass.
No, nodal. Where do you look for supraclavicular node? Where is it?
Right supraclavicular.
Where is it?
With level 4.
Which is, what is supraclavicular fossa?
So between the two heads of sternocleidomastoid muscle.
So posterior triangle is not supraclavicular. Level 5 node, is it a supraclavicular node or not?
So the nodes that we use for level 4.
Level 4B will be right. So it is between the two heads of the sternocleidomastoid. Especially when you are talking about internal malignancy like this, we see the, but breast, even the level 5 is also the supraclavicular node. Now, why do you want to look for the supraclavicular node? What is the pathway?
So thoracic gastric will be and retrograde.
Retrograde. What do you mean retrograde? If thoracic diet, retrograde, it will come back to the thoracic diet and come back to the abdomen.
Not internal.
Some junction is there.
Between internal jugular and subclavian.
Perhaps junction. So the retrograde through the retrograde thoracic diet. There is also other nodes. Okay.
There is no valve there at that junction, and so there is a reflux from here which leads to.
Is it possible?
No.
So suppose in this case you see the level 4 node is palpable. What is the stage? What is it? Is it N or M? Suppose the breast you are seeing the supraclavicular node. That is N3C. This is a node. Here it is a metastasis. Okay.
Examination. CNS, no focal neurological deficit. CVS, S1, S2 word, no murmurs. Respiratory system, bilateral laryngeal present, normal vesicular response word. Summary.
What focal neurological deficit you look for? Again, that is one of the very, finding out focal neurological deficit is a very long neurological examination. You will not be able to do that within available 40 minutes which is given to you. You are only going to see an obvious neurological deficit. Or what are the neurological deficits you will expect in this case? Okay.
68-year-old gentleman plus history of alcohol consumption and smoking for the last 30 years. Presented to the OPD with chief complaints of epigastric pain for the last 2 months, vomiting for the last 2 months, which occurred almost every day for the past 1 week, 4 to 5 episodes per day, loss of appetite, loss of weight, generalized weakness and fatigability, history of bowel illness present, reduced frequency of bowel habits. On examination, there is an epigastric mass present, hard consistency, non-tender, moves with respiration, visible gastric peristalsis seen, succussion/process.
Which is epigastric.
Boundaries. Where is it?
Which is midway between the sigmoid process and
How big is this area? Memorize the lines and the planes, okay?
So you will be able to measure Is there any other way? You are right saying it is specified to the fixed prices. You don't have a time to measure all those things exactly. Vertebra is angle you can't make it. Where do you draw the line? In the surface point, it is an angle of the wall. How do you draw the midclavicular line? You see the nipple? So that is apparently on the midclavicular. You don't go and measure from the acromion point, the joint and make it. And similarly, it is only just below the tip of the ninth costal cartilage. So we are going to make that here. So that.
How big is this area? Is it limited to epigastric area?
It is a very small area, unless it is a very individual. So never will you have a mass which is only confined to the epigastric area, or fullness only in the epigastric area.
So
You know any other space there? You know, here, top space? Okay.
the probable diagnosis is gastric outlet obstruction, probably due to gastric carcinoma without any clinical signs of distal metastasis.
There is a BGP is present or not?
Yes, sir.
A good BGP indicate malignancy or benign.
Benign. VGP is more pronounced to be seen in benign conditions than in malignancy.
You said you have a good BGP.
It's a mild, not very, not a large case, sir.
Large. There is nothing called large VGP and mild.
Maximum dilatation of the stomach, we can add that point.
Dilation of the stomach
There is, your case has no dilation.
this is more showing towards malignancy. Yes, sir.
Is there any malignancy in which the size of the stomach may be small?
What is that?
Diffuse
Malignancy is vascular.
Can a stomach carcinoma comes without gastric outlet obstruction?
Yes. Yes, sir.
What is it? There is no gastric outlet obstruction, but there is early satiety, and you are making a diagnosis. It will be a body, very good body,
body of the stomach.
or fundus.
Fundus and body of the stomach, it will say that.
Any difference? You have some tumor is in the fundus, tumor is in the antrum, pylorus. Any causative organism?
H. pylori. H. pylori is caused for tumor in the distal part of the stomach and body. Proximal is
So will you confirm your diagnosis?
we have to
See, to investigations.
Oh, confirm.
component is apogee
Right?
with biopsy.
With biopsy. Then staging investigations. If it is confirmed, staging investigations.
Any maneuver that is done in upper GI endoscopy to see the fundus?
How do you visualize the fundus by using the scope?
One letter in ABCD.
J.
J or U, madam?
Sir, okay, when do you say it's a early stomach, CS stomach?
And only mucous and submucous are involved regardless of the motor status.
Can you, in this case, clinically say whether the malignancy is early or advanced?
This is an abdominal mass, so we expect it to be an advanced stage.
Good. So on endoscopy, how to differentiate is a benign ulcer or malignant ulcer?
It will be converging, malignant ulcer will be converging to
The located converge towards the ulcer.
Site.
Site data curvature is mostly malignancy, and lesser curvature will be mostly in the benign. And
Which malignancies are more likely to present in an advanced stage? Those in the lesser ulcer or greater curvature? Lesser curvature or greater curvature? Which malignancies are more likely to be locally advanced?
Locally advanced greater or sorry.
Yeah, lesser or greater?
Lesser also.
Yeah. Why?
It is very close to what? When you say it is inoperable cancer. Now the term is not acceptable. There is something called inoperable nowadays. Okay, you've done enough for GA. What do you want to do? It is confirmed. Which carcinoma it is? Squamous cell carcinoma? What is adenocarcinoma? What will be the histology? Okay, go and read. So you have confirmed it is a adenocarcinoma. Lower. Yeah. What do you want to do? So there is no metastasis. It's only stage 2.
So then we move for treatment. Treatment will be
Neoadjuvant chemotherapy leads to gastrectomy.
so if it's operable, then it will be since there's no medicine that we offer, the key to subtotal gastrectomy with reconstruction. So reconstruction mostly low in my gastrectomy.
What do you mean subtotal gastrectomy?
80% of the stomach.
So how do you measure 80% of original or distended?
80% of the originals.
What is that? How do you pay 80%? If there is any particular line or somewhere. Okay, you read and what is the margin you are going to give
5 centimeters.
for all diffuse and so at least your level is what is going to deep gastrectomy?
So M1 and M2 treatment also.
Only environment.
Twice station of most service.
Will you do level 10?
We need not do that.
So will you do spring lecture?
Not all.
Any role of chemotherapy?
Chemotherapy.
5 to
We can give neoadjuvant chemotherapy to downsize the tumor and then go for gastrectomy. We go for triple regimen, cisplatin, epidural.
What is the prognosis of patients of carcinoma stomach?
5 years, 5 years survival is 20%.
Or can what stage? 5 years, 7-20% or all?
It is supposed to be the captain of men's death.
So suppose inoperable, you are not able to do
For palliation,
what palliation?
if it's resectable, we go for palliative partial gastrectomy.
Not possible. Which gastro bypass will do? Is there any difference between the bypass in a benign condition and malignant condition?
GJ posterior.
Anterior.
Benign?
What do you do in anastomosis? Expand, abbreviation, no?
Posterior, isoperistaltic, vertical, sharp. Okay, good. I think you are. So this is only when we go to the surgery and it's only when you are doing well. You are relatively well seen the case where presented the points and it is easy in the examination, undergraduate examination. If you get a stomach cancer, you are lucky, but not hernia and thyroid.
And again, optimize all your patients. Do talk about maintaining nutrition in these patients of carcinoma stomach. You may need to give either TPN or even do a feeding jejunostomy for them prior to surgery. And another thing that you must talk about is adequate hydration prior to surgery, wherein you may need to repeat CBC also. Because when you admit them, false readings of high hemoglobin come. But as soon as you hydrate, they may go down to 2 or 4 also. So they may need some blood prior to surgery. Well done.
Thank you.